Let's get started so we can all go home.
Yes. Oh my God, yes.
We're going to talk about this, but not quite yet. So how many of you looked at the extra credit video?
I already did it.
How many of you want to be cardio converted with a little 100-joule joke?
No, thank you.
Yeah.
For not.
Yeah, no, so about 8 years ago I went in and said, I've been rapid AFib, and luckily the diltiazem worked for me.
Oh, okay.
So I converted without having to be zapped. But what did you think? What did you think of that? I mean, that was a real emergency room. What did
They did not sedate the guy enough, but
yeah.
The reason.
Okay, wait. We got to give everybody their own chance here.
I just wanted to say I was in the room when my patient was getting procedural cardioversion, and it was really similar, except they didn't have pain like that man did.
Why do you think they didn't sedate him as heavily as they could have?
It was because his blood pressure was low.
So that brings up the point I wanted to ask y'all, because this is kind of a physiology moment, even though we're in farm.
Yeah.
Why was his blood pressure, what was it, like 95 over 50?
Yeah, something like that.
something over 65.
Yeah.
He was withdrawing from alcohol.
That could have been it, but there's actually a more immediate reason if you think about it.
Compensating for such a high pulse.
Well, since
High pulse rate is on track. We're getting there, getting
so
closer.
if it was AFib, the atrium are like.
He's not an AFib.
Okay.
Because it's not giving time to fill up.
There you go. Okay, his heart is going this fast. He gets a quarter of a second, 250 milliseconds for the whole cycle. So how long does it have to fill? Like 100, tenth of a second? So there's no blood going in. And if there's no blood going in, is there any blood going out? So it has to do with that such a rapid heart rate. Even though the ventricles are contracting appropriately. So the difference between like PSVT and something like this, this is a wide, complex, monomorphic. PSVT has a normal, narrow complex. And, well, let's get rid of the P. The P is paroxysmal. It just means it's kind of random. It can kind of happen at any time. Things that will trigger it will be dehydration, alcohol withdrawal, drugs, all kinds of stuff. The SVT, supraventricular tachycardia. In other words, the impulses making the ventricles beat are coming from the atria. Now, whether it's the SA node, which probably not in this case, or some other, foci that is going boom, 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 or maybe it's a reentrant syndrome. You'll hear about WPW, Wolff-Parkinson-White syndrome at some point. Whether he had one of those going on or not, I don't know. But his issue was that his heart was going so fast that it couldn't fill. Because when does the heart fill?
A diastole.
Did you say diastole?
Diastole.
Yeah, my hearing's failing. So during and diastole for him is lasting like 100th of a second. Excuse me, 10th of a second. It's just there's not enough time to get any blood in. So what did you think of his whole experience? I appreciated the doctor. I like ED docs who say things like, it's going to feel like somebody hit you with a baseball bat. Because that's the truth.
The videos went on, at least mine did, like my computer, if you just don't click anything, it'll go on to a next YouTube video that's similar, and it was the same thing. It was like some, kind of macho looking guy, like super out of it. And they were like, all right, we're going to convert, and all of a sudden you're like,
was this the one with the guy that was about like maybe 35 or 40? Yeah, I didn't put that one up directly because he kind of gets even a little more obscene in some of the things.
He was like about to.
Yeah, so I decided it was actually the first one was instructive enough.
It was interesting. Both of them had the similar, like you could.
Yeah. So getting back to his sedation, why do you think they didn't sedate him quite as heavily as they could have? His blood pressure was already 90 over 60 or whatever, and Versed's going to drop your blood pressure more or can. So he wasn't in a position where they could really heavily take him down. Now the thing is, 30 minutes later, he's not going to, other than knowing that he's sore, he's not going to really remember the procedure because of the Versed. It has that retrograde amnesia thing going. So, that's actually being, that's the whole compassionate cruelty thing. It's going to hurt. It's going to last a minute, and then later you'll forget we ever did that to you. And then we can do it again. Yeah. Oh, we're all a little sadistic. So what did you think of the quiz? Was it?
Fine.
Did you all do the reading first, I hope? Yeah. Did it seem reasonable?
Yeah.
So it's kind of in line with the kinds of questions I'll be asking on the midterm. It's all coming from the same source. So if you're doing well on the quiz, you should be heading in the right direction. And I've been trying to explain this to my juniors, so I'm going to explain it to you too, because I haven't really talked about it this way before. I'm still evolving as an instructor. I'm figuring about 30% of the questions will come from the reading, and the quizzes are going to be based entirely on the reading. So my lectures don't really cover what's going to be on the quizzes. The quizzes cover what the reading hopefully you've done. And for the midterm, which last semester I gave them the option of 1 or 2, we're going to go for 2 because people were stressing out that they only had one chance and there weren't enough test questions, and they were afraid that all the questions counted too much. So yes, there's an extra test, more questions, but the goal is to give you a little more room to work with. If you miss one, it's not the end of the world. But about a third of the questions on the midterms and the final will be driven or derived from the reading. And the other 2/3 will come out of the lectures and what I've talked about. The goal is to beat you into submission about doing the extra reading that nobody wants to do. I had one student, one of my juniors last semester says, "I hate reading." I'm like, why did you get into this program? What were you thinking about? Questions about what you've read about, or what were, or the procedure, what you saw, anything like that you want to ask? Yeah.
Well, I have like a kind of, so when you do cardioversion, would you ever do like an ablation before cardioversion type thing?
No, because you can't do an ablation with somebody that's running at 200. They have to be under control first. I had an ablation done.
Well, because my grandpa just had an ablation done, but he was never cardioverted beforehand. I mean, he was on.
Well, but was he one of those that was like chronic AFib?
No, but he's like COP smoker type thing.
Well, he must have some kind of dysrhythmia for them to do an ablation.
Yeah, he was AFib.
Okay, so but he's probably chronic AFib. There's no way, it's not correctable. So they're going to rate control him probably with something like a beta blocker and a calcium channel blocker just to get his rate down, and then they're going to go in and see if they can figure out where is the location that's triggering his AFib. Sometimes they do an ablation, sometimes they do a crisscross pattern. What they're looking for is those cells that are firing, and ablation is another nice word for taking a microwave and zapping it and killing those cells. Is really what it accomplishes, and leaves scar tissue behind.
No, I was just kidding.
Okay.
Yeah. How often does adenosine have no effect, or does that?
Well, adenosine pretty much always has an effect, but it
doesn't always correct the issue.
Yeah, and it depends on what the underlying diagnosis is. So most of the time adenosine doesn't work.
Oh, interesting.
But now, did any of you take? I didn't actually put the other ones up there. There was other videos. If you Google adenosine on YouTube, you'll see a whole bunch of 2 and 3 second pauses. Now the patient won't remember it because their eyes roll up and they wake back up and they don't know that their heart stopped for 2 or 3 seconds. But if you're not expecting that their heart is going to stop for 2 or 3 seconds, you may be the one that they're doing CPR on, picking you up off the floor. So what is adenosine?
Restarts your heart pretty much.
Have you ever heard of adenosine before?
Yeah. Isn't it like natural? Well, no.
What's ATP?
Huh? Like adenosine triphosphate?
That's adenosine.
Yeah.
That's why it's got a 10-second half-life.
Okay.
The body says, we like this stuff. It uses it up.
Right.
That's why it's so short. So the way they administer adenosine is usually have their, I'm laying down. They got the arm up, the IV, and it's a rapid push.
Yeah.
Because it's got to get from here to here before it's gone.
Yeah.
But what it'll do is it slows the heart long enough for them to get a rhythm that they can actually read with a 12 lead. So they can say, oh, well, here's what's really going on with this patient. So they can figure out, will an ablation work or something like that. So they can figure out, what is triggering this rapid heart rate.
So you said slows the heart to get what?
Well, okay, so when somebody's running like at 230, the EKG just looks like, you can't see P waves at all. You can't see So what it does is it slows the rate down enough that you can actually get an EKG that looks like this, and you can see if there's what other aberrant things are going on. So it just serves to give you another picture. And in some cases, depending on the kind of what the underlying cause is, which I actually don't remember, it can actually fix certain kinds of AFib. But in most cases, it just stops and it's a diagnostic. So his sequence was they did a vagal maneuver, and then they did diltiazem twice. Yeah, that was what was hard to hear, was diltiazem, which is the calcium channel blocker. They actually tried him at 2 different levels of DILT. I don't think they did adenosine with him. Did they? So they went. That was their progression before they tried. They finally said, "Okay, we're going to have to cardiovert him." Why do you think they ultimately had to cardiovert him?
It wasn't big. Nothing's working.
How long was he going to live with a heart rate of 240? I mean, at some point, his heart's going to say, "I quit." Yeah. So, I mean, this was actually a life-saving maneuver. Want to talk about antidysrhythmics? Not really? Sure. Shall we all go home? No, okay. I don't get to go home. I have my meeting to go to. I get to go get counseled on diet. Wednesday nights are my meeting for my weight management program. So, the other reason to go is I get my week's worth of food. It is, that's one of the reasons I show up. Food! 42 boxes of shakes. Anyway. So, I am not going to teach you how to read a 12 lead because it's been too long. I don't remember anymore. Reading 12 leads actually requires you do it kind of like every day to stay in practice. But, the first time you take a 12 lead, if you count the leads, how many leads are there?
10. Isn't it 10?
I think it's 11.
Yeah, not 12.
Yeah, there's not 12. The 12th is actually inferred. So the system creates it, but it's based on the analysis of everything else. Do we understand, even though I'm not going to tell you how this gets from here to there and all that stuff, do you understand the reason for why waves are up or down? Do you remember why? I talked about it very briefly a year ago.
Where the electrodes placed?
Heart problem.
No, actually, that's not it.
Where?
Okay, so remember that you've got this wave of depolarization, right? Well, if where the electrode is, or the sensor really, if that wave of depolarization is running towards it, the wave will be up. If it's running away from it, it'll be down. Now, the reason you want to really know that and just kind of remember it, if you're looking at this one and it's inverted, it's either they got a real serious heart problem or somebody's put the leads on wrong. So the first thing you do is check the leads. Do they have the wrong? And it happens, they get a bath and somebody's in a hurry and they just put leads back on. So when you're looking at an EKG and it just looks really wrong, check the leads. Always start with the patient. Check the patient. Check the leads. So we would look at this and say, he's having runs, 3 and 4 beat runs of PVCs, pre-ventricular contractions. Now, PVCs in themselves are not necessarily worrisome. What makes them worrisome is that they're happening again and again every minute or every 10 minutes or whatever. They're indicative of some irritability in the heart. Why is a PVC this wide complex? How is it different than this narrow complex? Anybody remember or know? Anybody want to hazard a guess?
Can you repeat your question one more time?
Okay. You notice that here it's a very narrow complex.
Yeah.
Delayed.
You're on the right track there. So, and these are wider. So you got to remember this is a time base. So for some reason, PVCs take longer to happen than a normal heartbeat. Want to think about it some more? Or shall I take you out of your suspense?
I don't think any of us know.
Mia knows.
I just have a question.
Oh, okay.
We can talk about it later.
Okay. Well, I don't care. Ask your question. It's fine.
If somebody has the inverted thing like you were talking about, could it be like from having like 2 bicuspids and not like 1 bi and 1 tri?
I honestly don't know the answer to that.
Okay.
And I'm not going to hazard.
Mine is inverted. And my mom doesn't have. She has 2 bis.
Oh, interesting.
Find the tri on me and some.
That's kind of cool. I mean, I'm going to say this as that's kind of cool. I'm going to assume it's okay. You appear to be alive. Oh, yeah, we all have our moments, you know. I don't know how the valve differences would necessarily affect electrical conduction. It sounds more like you've got some kind of conduction abnormality as well. Maybe the fact that things are physically laid out differently changes the conduction pathway. That's all I could think of. But I'm guessing.
So, so delayed depolarization and repolarization, meaning the heart is working a lot slower? And not.
Yes, you're right, but I'll explain why you're right.
Okay.
Normally, it goes down to the SA node, AV node, down the Purkinje's and out. And it's a very efficient conduction pathway. When you have a PVC or these this guy that's, it's VTAC, that's called a tombstone rhythm. I'm serious. That's what it's called. Not just because of what it looks like, but usually what it leads to. It's both. In this case, you've got some other part of the ventricle that says, we should beat now. But instead of going down that conduction pathway, it propagates all the way around the heart because all the cells are connected. And they respond to either impulse. So if there's one coming down the conduction pathway, they all in a coordinated fashion go, yep. But if it comes from some other place, they all say, oh, I guess I'm supposed to fire now. And so it will propagate very slowly by comparison around the heart, and that's why it's a wide complex and irregular. That's also why it's a less efficient kind of beat. Now, this is not necessarily fatal. You can have people that are in VTAC for quite some while before their eyes roll up. Some of them kind of live there. Well, not really, but not for very long. But this is generally considered, when you're taking the NCLEX, this is a rhythm you want to be able to recognize. Because they might. I don't think they ask you about first, second, third degree third-degree block they might.
So that's a third-degree block?
That's VTAC.
Okay.
A third-degree block, we'll back up, we'll talk about this later. Okay, there's 4 kinds of heart block. We're not going to go into detail on it, but anybody, we haven't talked about this in MedSurg 3 yet. I know you will. Anybody know what a first-degree block is? Okay, what does the block refer to?
Where it's like the first degree block is like one's just late or the P wave just doesn't come on the first time. Like I remember
you're kind of close, but before we get everybody confused with
Comes home
where like the wife comes home,
late.
the husband comes home, but then he comes home late one night. And then
so that's second degree.
Okay.
Okay, first degree.
But I remember that story.
Mm-hmm.
Well, hey, if that works for you, it just needs to be cleaned up a bit.
Yeah.
Still get figure out what story is.
Yeah.
Okay.
What's block? Block is blocking the
Let's talk about block. So you have an impulse that goes from the SA node to the AV node to the whole thing, right?
Yeah.
So what do you think a block means?
Block the impulse.
It's slowing or blocking the impulse. First degree block is just a slowing. So what happens is the AV node fires, the SA node fires. It hits the AV node and it takes just a little more, maybe there's a little scar tissue there with some damage. But eventually it gets all the way through and you have a normal P wave. It's just that the PR interval, instead of being 0.2 or less seconds, is greater than 0.2 seconds. But it's regular. The PR, So the interval from the start of the P wave to the start of the QRS complex is,
That's going to be
if it's greater than 0.2, but there's always a P wave, and it's always, if you have like 0.22, and it's every time it's regular, that everything never changes, that's first degree block. Now, as you said, Janelle, with the first one's at 0.2, and the second one's at 0.22, and the third one's at 0.3, and then it misses all together with the P wave, that's type 2. That's a secondary block. And then there's Mobitz, and it's too hard to explain at the moment, but third degree block says there is no communication between the atria and the ventricles. They are beating independently of each other. And the reason that matters, and we'll talk about this in a few weeks when we talk about ACLS protocols. First degree block, what do you do? Did somebody say monitor?
Yeah.
You just watch. There's, remember you remember because you haven't done it yet. You're going to do your sim day. And a year ago, one of my students, everybody brought, they brought their sports bras or bikini tops or whatever, and we did it 12 leads on each other. And one of my very fit, healthy students was in first degree block.
Wow.
It's just, and I said, you might want to double check with your PCP, it's probably nothing, but you want to know, if nothing else, you have a baseline, that, historically already you have first degree block. Typically, it's no big deal. If it's new onset and it's your 88-year-old, whoever, your patient, then you're going to be paying closer attention. But again, there is no attempt to cure or modify. You're just going to pay attention. Second degree block, you're still going to be paying attention, because if it gets progressively worse, or if it progresses into third degree block, you're going to be doing things like putting them on a pacemaker or whatever. Third degree block is paced. They have to have a pacemaker, because they end up in what's called, like, maybe you haven't heard this yet, an escape rhythm. So you got multiple pacemakers. We got the SA node, the AV node, Purkinje nodes. The escape rhythm is the muscle cell itself, which usually is a rate like around 20. And the reason it's called escape rhythm is they're escaping death. Hopefully. So these different pacemakers, you will actually base, you can have you can have a tachycardia that is actually driven from the ventricles, and so you can have the brain is just gone, I'm sorry. I'll save that discussion for later, because I don't even have slides to talk about what I'm talking about. Yeah.
Does
accelerated junctional rhythm. There we go.
Heart block doesn't necessarily mean that it's going to lead to 2 and 3.
Not necessarily.
Okay. So they can keep one.
They may be that way for the rest of their life. It's okay. 2 is more concerning, because it can develop into 3. Yeah.
Now the top one,
These are PVCs.
which is
Preventricular contractions. These are often due to chemical imbalances, some kind of irritant in, whether it's some part of the heart that's not happy. You can trigger these, like when they place a central line. If they get it in too far and they touch the wall of the ventricle, you'll trigger PVCs. That's one of the things that they look for. Is we've got to pull back a little bit. This is different than PACs, premature atrial contractions. These are more serious. But
these are more serious.
yeah, because these really actually affect the cardiac output. But still, in terms of your nursing care, what you're really looking at is their duration and their frequency. If they're only occasional and it's 2 or 3 beats, you're going to chart it. He's been having 2 to 3 beat runs every 10 minutes, every half hour, whatever, because that's what you're going to pass on a report. Because the next nurse wants to know that, now he's having 5 beat runs every 5 minutes. Something's getting worse, whether it's electrolytes or whatever. You look up and see this, it's time to call the code. Even if your patient's looking at you and talking to you, you want to know what's going on. And it's possible that they'll be in VTAC and they will be talking to you, but most people will not. And this is a normal rhythm, a normal 12 lead. And we're not.
That's all
Oh, the
one.
whole entire thing.
You'll see there's AVR, there's lead 1, lead 2, lead 3. Anyway, we're not going to explain that today because I don't remember it. So let's talk about atrial stuff first. This is atrial flutter. Flutter is different than fibrillation, but they're closely related. Flutter says it's actually, you see it's actually a regular wave. It looks like lots of P waves. And typically the way you will chart this is that they're in atrial flutter. Now this one's a little irregular, but often what you'll see if it's in flutter, which actually doesn't happen all that often, but you'll see like maybe you get a QRS complex every third P wave. So you actually will chart they're in A flutter with a 3-to-1 conduction or 4-to-1 conduction. Every fourth beat you get a QRS, or every third beat you get a QRS. And usually they tend to be a relatively irregular dysrhythmia. What's the problem with flutter? Well, if your atria are not beating effectively, you're losing that bit of supercharging that they do that helps the ventricles expand a little further and increase the strength of stroke and also reduces cardiac output. What is the contribution to your cardiac output of your atria? If your atria are working correctly and then they stop working correctly, what does that do to your cardiac output?
Diminishes it because you're not getting enough blood to pump out.
How much does it diminish it?
Does it depend on your flutter, or does it depend on whether you're having flutter? Or
No, there's basically an expectation about how much the atria contribute to your output. It's around 20, 25. So if it's a new onset, you've never had AFib or A-flutter before, and you suddenly develop it, what is likely to be the experience for the person?
Tired.
Tired? Yeah.
Doesn't it feel like butterflies?
It can feel like that, and then feel tired, lack of energy. What happens if you stand up quickly? You might go right back down. Yeah, that's called a syncopal event. We know that word, right? We like syncope. Syncope is a good word. I like it. It has multiple syllables in it. Okay, so what do we treat this with? Beta blockers, calcium channel blockers. Now, beta blockers, of course, suppress both ventricular and atrial rhythms because they affect the beta receptors. And an analogy I thought of last semester, we'll see if it works for you guys. If you think of the receptors as the door with a keyhole, and the key as the beta blocker, if you put the key in the keyhole, can you put another key in?
Nope.
So it is blocking the receptor. So think of blockers as things that fit the keyhole, and nothing, as long as they're sitting in that keyhole, nobody else can get in. But these work at the level of, they're autonomic nervous. It's a neurotransmitter, and you're blocking that neurotransmitter that tells the heart to go faster, because the beta blocker is sitting on that beta site, blocking the impulse of the neurotransmitter. What kind of beta receptors do we have? What kinds?
1 and
Beta
2.
two.
And where do they live?
1 in the heart. 1 in the heart, 2 in the lung.
There we go. And how do you remember it?
We only have 1 heart and we have 2 lungs.
There we go. You guys are so good. You'll be able to at least get one question right in the NCLEX now. If they ask you that one. Actually, it's a very common question, from what I understand. Calcium channel blockers work a little differently in that they actually impair the conduction, the contraction of the muscle itself. So they also tend to slow the heart rate. So both of these will slow heart rate. And so like with your grandfather, where they probably had him on both to try and keep his rate, they were trying to achieve a rate control with chemicals, and then the thought was they would, if they did a femoral access or through the arm?
I got to change the dressing.
Oh, weren't you lucky?
And then I accidentally.
I don't know if I want to change dressings of my grandmother and stuff. It's like, that'd be a little weird.
Well, I mean, my grandma had like back surgery, so I was her nurse for that. So
Yeah, well, that's different, you know. But it's like when my mom started showing me, she's just pulling her pants. Mom, don't do that.
it was really funny. Me and my grandma became really close.
Well, I'm glad. That's a good outcome. We like that. So AFib, the difference is instead of that regular flutter wave, AFib is just, you know, the atria are just doing this. They're quivering. So once again, you know, you lose the term for it is atrial kick. You lose that little bit of supercharging at 25%, 20%. Same treatment, you know, beta blockers. Our guy for the video was in PSVT, paroxysmal supraventricular tachycardia, and it helps control their rate. So let's talk a little more about PSVT. So this is where they have a rate of 180 to 200 bit or more, you know, per minute. And like I said, when you think about it, that's 3 or 4 beats per second. It's a lot. Yeah, they opened those this morning, and they're probably just needing to be closed. It's getting chilly out there. So we talked briefly about adenosine with our guy. So it's both a diagnostic and a treatment. In some cases it treats, often it doesn't. But in both cases it stops the heart long enough, and then it starts out a little slow before it starts running fast. And that's how they can get the EKG they need. Beta blockers, again, calcium channel blockers. Is this looking familiar?
Yeah.
Okay, so if it's rate control we're looking for, that's what we do. So let's talk a little bit more about PVCs. So these are, like I said, these impulses come from the ventricle as opposed to coming down from above, from the atria. Often, you know, the treatment of choice for years and years and years was lidocaine to control rate. But, you know, lidocaine's old, it's cheap. Let's use something else that's more expensive and newer and cool. But actually, lidocaine's still very effective. It's got its own side effects you have to be concerned about. You'll get to read about those. Amiodarone. You're going to see that a lot in the hospital, especially in the step-down units and stuff. I'm sorry, I have to sit down. I'm just dying. It's been a long day. There is a side effect of amiodarone that it can be quite concerning. And do you want your glasses?
Yeah, I'll grab them.
Okay. As the nurse who's caring for this patient that's on an amiodarone drip, you need to be paying special attention to their EKG. Now, you know, when you work in the ICU or step-down unit, actually one of the first things you do when you come on shift is you run a strip on every one of your patients so you have a baseline. It's part of your beginning assessment. You want to know what their heart's doing right now so that later if it changes you can look at it and say, well, that's different. Have any of you read about amiodarone yet? It wasn't assigned necessarily. I'm not trying to beat you up in any way. Just wondering if anybody's had experience with it. No, it doesn't. Well, it may end up in asystole, but it's not immediately what you're looking for. No. So bless you. What amiodarone can do is prolong the QT interval. So what do you think that might lead to?
Lower heart rate.
Well, no. So where's the T wave? You know, you got the P, QRS, T. That's at the other end. So if you have extend the T wave, what's happening? Is it getting closer to the QRS complex? Yeah. Is there a concern with that? Very good. I like that answer. Okay. Have you ever heard of R on T? Oh, you will.
What is it?
It's an R on T. And, of course, my ACLS instructor was named Ron T. He thought this was great. But So what happens is you get that R impulse somewhere on the T wave. So if you have a really delayed T wave and you hit it with that R impulse, depending on where you are in the repolarization of the heart, because the T wave is ventricular repolarization. Okay. When you look at that T wave, for the first half or so, it is refractory to any impulse. That means you could hit it with a hammer and it doesn't care. But after it's kind of past the midpoint, it becomes partially reactive to an impulse. And it can trigger torsades de pointe. It can trigger this weird VTAC that looks sort of like a slinky or an FM signal, really. And so what you want to be concerned about as the nurse is if they have a lengthening QT interval, they are at risk for torsades, which can be a fatal, well, just fatal rhythm, not fatal, but just fatal. And I'll have a picture of that coming up in a little bit here.
Now, why would someone be prescribed amiodarone if they don't have previous ventricular?
Well, if they've had a heart attack and stuff like that, and they're exhibiting other, it's amiodarone's another kind of antidysrhythmic. What's the primary problem with antidysrhythmics as a side effect? Dysrhythmias, yeah. It's a classic. Exactly. The thing you're giving it to prevent, it causes. And it's not at all uncommon. So let's talk about VTAC a little bit. This is non-sustained. So a run of PVCs, this 4-beat run, 3-beat run, these are actually runs of VTAC. You're in ventricular tachycardia because it's all ventricular beats. This is sustained, and it's, like I said, it's a tombstone rhythm, potentially fatal. You're probably going to be, if you're not having called the rapid response team, you're getting ready to call a code.
So should we really have these visuals in our head of what is what?
You should know what this is. You should know what this is. You should know a PVC. You should be able to identify a PVC. Yes, and you should be able to identify VTAC. Because for the NCLEX, you need to know the fatal rhythms. This is one of them. Okay. If you see this rhythm on the NCLEX, you need to say, this patient could die, and whatever answer is appropriate to why it's a concerning rhythm. Typical meds? Oh, my God, we're back to lidocaine, amiodarone, in ACLS protocol. And we'll talk about the ACLS protocol, and it's like 3 or 4 weeks out. We'll actually talk about the drugs, the sequence of drugs, who's running the code. The protocol tells you whether or not you're going to monitor, whether you're going to actually intervene, and what the order of intervention is, which drugs go first. It's actually not that hard. Here's my thought about ACLS before you get a job. Since October, Kaiser has advertised 350 new positions within 35 miles of my house, which is 5 hospitals. Sutter is doing the same. Everybody has finally decided we need nurses. Do you know what an ACLS class costs? Have any of you looked into it? Upwards of 500, depending on who you take it from. However, if you get hired, virtually every hospital wants you to be ACLS certified. Guess what? They will pay you. They will pay for the course and pay you to go to school. I don't think at this point, as the job market evolves, you need to have your ACLS certification before you show up. Yeah.
What if you want to go into a specialty like the ED?
Even there, they'll hire you in and send you. If Kaiser used to run, and I think they will be again in the future, running their new grad program, because that's how they're going to compete with Sutter. That's, right now Sutter and others have sort of formed this consortium, and for a mere $800, you can go to Sonoma State, take another semester, and get, sort of ready to actually be a real nurse in the hospital. Now, Kaiser used to do that, except Kaiser put you through anywhere from a 4 to 12-week training program and paid you the whole time to go to training. Kaiser is effective at competing that way. So if they feel they're not getting the nurses they need, they will just reinstitute that program so that, well, if you come work for Kaiser, we're going to pay you $40 an hour to go to class, and if you work for Sutter, you're going to be out $1,000, and you're going to have to wait 2 months before you can get a job, and maybe they'll hire you. They can't promise you a job. That's illegal. So anyway, it's entirely up to you. And I would hate to be the ones that, well, Bob said don't get ACLS, and I didn't get the job because of it.
No, I think some people in the last semester are doing that because they need extra hours. Well,
there is that thought, but that's a different. So anyway, the job market's getting much more similar to what it was when I entered. And at that time, it was like, you're breathing, you have an RN? Good, come in. We'll train you. It's good. So if you can get by without spending the money, make somebody, do this. This is that classic do it on other people's money. Let Kaiser pay your way, or Sutter, or whoever. This is torsades. This is what you don't want to see on a monitor, let me tell you. But what leads into this is that R on T. So if you have a patient on amiodarone, and that T wave is getting further and further out, which means it's getting closer and closer to the P, and QRS, you need to be paying attention to that. And that is the time you call the doctors. Hey, doctor, Mr. Jones, his QT intervals has gotten to this long, and he's on amiodarone at this. What do you want to do? And he'll say something like, or she'll say, oh, let's change them over to, we'll stop it for a while or whatever. Because you don't want to see this. You see this on the NCLEX, this one's dying if you don't intervene, and even then you may not save them, depends. So VFib. So we talked a little bit about AFib, so the atria are doing this. Now we got ventricles doing this. Is there any blood flow?
0. Well, a little bit.
No, none at all. Not until you're doing. Have any of you done CPR yet? On a real person?
No.
Yeah.
Who said yeah? What was it like? Was it hard?
Yeah.
Was it weird?
I switched with the.
You were switched.
EMT tech.
Uh-huh.
And it was just a lot of. I don't know. It was just tiring after
It's exhausting.
After 3 rounds.
Yeah, it's like you go for a minute and you're like, oh my God, this is hard.
Intense.
Had they already, the first time, you actually do not break people's ribs doing CPR. But your sensation, if you're the first one to start it, especially if it's that 90-year-old little lady, you're going to go, it's very unsettling, disconcerting. Actually, it's the cartilage. You're really going for it there, aren't you? Okay, so the cartilage separates, and it gives you the sensation that you're breaking the ribs. It's weird. And later, assuming that you save them, they're going to say, "My chest really hurts. What did you do to me?" Well, you were dead. We brought you back. Actually, that's I have to agree with my ACLS instructor. His intro was, when you're working with a dead person, because when they're doing this, they're dead. The only thing that's going to bring them back is your intervention and your success, the quality of your compressions, aeration. So what's the new protocol for BLS and ACLS?
C.
Compressions never stop, right?
Mm-hmm.
What's the rate?
100 per minute.
So how fast is that?
A lot. Staying alive.
It's about.
Yeah, I know.
Yeah. You do that for a minute. If you're not doing it right, you'll be on the floor and they'll be doing CPR on you. Yeah, it's hard work. But their survival is dependent on your compressing their chest enough to push blood. Because it doesn't matter how well you are ventilating that patient. If the blood ain't circulating, it doesn't matter. So that's why they came up with this. Don't stop, just compressions all the time. What's the one time you stop? No, you don't stop for breathing.
Check vitals.
They start.
Defibrillators.
Defibrillator. You do not want to be touching them when they give them that 150 joule shock, or you will be across the room saying, what the hell happened?
If not,
So if you're leaning up against the bed, you're going to have a little ride. Don't do it. That's why they call clear.
yeah.
Clear is not about that I'm clear. It's that, are you clear? Are you touching any part of anything metallic? Don't be near that bed. So there's different kinds. There's coarse, fine. It all equates to no blood flowing. And the whole ACLS protocol is why do you want to get the blood flowing? Well, the heart needs the blood too. It needs those nutrients and oxygen. And of course, the drugs that we're trying to get there to remind it to wake up and go back to work. And there's a whole structured protocol for VFib. And yeah, not that I wish this on any patient, but hopefully during your rotation, you may have the opportunity to give compressions or more. Actually, in my clinical up at North Bay last semester, they had given me 10 students, which I was thrilled about. So I was putting two students in the ED. And one day they came back and said, yeah, we were hanging the bags and we were doing this and we were doing compressions. And I'm like, what? And they saved the patient. Well, actually, it was, they were talking about it and I said, so how are you feeling about it? Because it doesn't sound like the patient. Well, the doctor was just explaining to the family about how their grandmother wasn't going to make it and she woke up. So it was like everybody felt good. I don't know if she actually made it out of the hospital, but I was all prepared to be dealing with two students who had just watched some 88-year-old lady die in front of them that they'd been working on it. It can be emotionally affecting. I mean, it depends. That same semester, I had one other student who's in their ICU rotation, and looking for patients that are ventilated and stuff like that, and it turned out one of the patients actually was being maintained for organ transplants. It was going to be harvested. And my student said, yeah, okay, that'd be interesting. I said, because they're a lot of work. They're a lot more work than a regular patient because you're trying to keep a dead person alive, to keep the body alive. What I didn't know and didn't find out until noon when I came back to visit was it was a 35-year-old woman who had given birth 3 months before and had an atriovenous malformation, and it had ruptured, and she had died due to just a massive bleed. That was emotionally pretty challenging, and I really needed to make sure that the student was okay, because that's not the same as taking care of the 90-year-old. She had a newborn at home and two other kids in a family, and it was...
Is this the athletic lady that they had at Kaiser?
No. This was up at North Bay.
Oh, okay.
Really tragic. But I've heard about that one too.
Yeah, for a while, but same kind of thing.
So that's... Some days are harder than others in this job, and hopefully you will all find good resources that will listen to you, that you can cry on our shoulder or whatever. And as much as I love my wife and family members, the stuff that we do, you often will find you need to talk to other nurses about, or other people that are in the profession, whether it's doctors or whatever. Because if you have to start explaining all the stuff that was going on, you don't get to talk about what's really in your heart. So, find support groups. Okay. Classification of antidysrhythmic drugs. For the test, it would be really good to know the difference between a 1A, a 1B, and a 1C, class 2, class 3. Okay. I hate to give you stuff to kind of memorize, but know this. This would be good.
So there's what they're doing. Okay, so class 1.
Yeah, sodium blockade, action potential duration, changes, plus or minus. You want to know kind of how they work.
So just the function class or the drugs as well there?
Well, you want to know these are sort of representative drugs. Yeah. Now you notice all beta blockers. That's a good thing to know.
That's class 2. We can remember that.
Yes. And amiodarone, class 3. You might really want to take a moment to think about ADIO. Right? That might show up on a quiz or a test. Lidocaine.
Are there any drugs out there that are not valid anymore?
I'm probably not going to ask you about these. Flecainide, propafenone, but phenytoin.
I feel like there's some we've seen, and then some of them.
You're going to see lidocaine, phenytoin, quinidine, all the beta blockers, amiodarone. Yeah, sotalol, I don't know. Verapamil, diazepam, dig, adenosine. You'll see all of those.
So
Basically, most of that list. Yeah. Isn't that? Yeah, that sucks, doesn't it? I'm sorry. There's actually a whole lot more drugs than that.
Oh, yeah.
This is yeah, kind of what you need to know. Adverse effects. Are we done?
Yeah.
Actually, I think this is my last slide for what it's worth.
Okay.
So, adverse effects.
Yeah.
I think I told the earlier class. No, I didn't. I was thinking about there might be an extra credit with this, but that's a different class. But you want to look at these lists of things, just get a handle on, these are all challenging drugs. And particularly if you're doing them in the ICU and stuff. Thanks for reminding me that class was over. You were at least gentle about it. I thought I had till 5:30. You know, I never know what time it is.
It's
Get up and leave.
Your go-tos for these are bradycardia, dysrhythmias, hypertension, nausea, and headache.
There you go.
For the most part. There you go.
Pulmonary toxicity is a good one to know too.
Oh, yeah.
Okay.
Well, and the deadly ones. But,
Oh, and dead, yes.
yeah.
May cause death.